With the Affordable Care Act, commonly known as Obamacare, the US health system changed from a fee-for-service system to a system called population health management. What are the major changes and how do they affect patients and payers and providers?
Yeah, so you're exactly right. The US healthcare system is changing. We're in the middle of the change. And we went from a fee-for-service system to one that's really focused on value-based care. And population health management is ultimately one of the things that are being incentivized as a result of the new payment models. In the past, under fee-for-service, doctors and hospitals would get paid more for providing more services. And so the incentive was to increase volume as opposed to focus on improved care or more valued care. Under the new model, doctors and hospitals are being paid to keep people healthy and to prolong the amount of time that patients need expensive sort of treatments.
And what effects does it have on patients?
So from the patient's perspective, in the past, the focus has been on doing more tests, if it wasn't clear, to err on the side of doing more. Under the new model, the focus is going to be more on what's best in terms of keeping the patient healthy, what's best in terms of slowing down the progression of disease before any major complications happen. And so I think this is going to be good for the patient.
So this shift in perspective from treating people's sickness to keeping people healthy, what effects does it have on doctors and on providers?
So I like to say we're going from a sick care system to a healthcare system, which is a welcomed sort of change. The effect on doctors and hospitals is massive because it's really asking them to rethink through the ways that they organize themselves and how they prioritize their activities. Previously, I think the system has been very provider-centric. The times that surgeries are scheduled for, the types of organizational structures that were in place were all generally at the expense of what was in the patient's best interest and what made providers most efficient. I think under this new system, providers, that includes doctors and hospitals, have to think through new structures, new partnerships, new approaches to do their work. That includes partnering with community-based organizations, maybe the local health department, maybe the local library, maybe grocery stores in the area, maybe the transportation system in the city doesn't accommodate the kinds of things that patients need. And maybe it's on the providers to now begin thinking through those issues so that it makes it easier for the patient to engage.
Do new partnerships already emerge?
So we are now sort of in the early phase of seeing some of the partnerships that are coming out of this. I think providers are being challenged with having to come up with new innovative ways to deal with what we call the social determinants of health. These are the circumstances in which people live, work, play, worship, engage in their lives, and the conditions in which these happen all affect their ultimate health. Providers have historically not been focused on those things. Sometimes those things are social issues, sometimes they're cultural issues, sometimes they're systems issues. Because the focus is now on keeping people healthy, anything that interferes with that suddenly becomes within the domain of providers' interest to focus upon.
What effects does population health management have on payers?
So, in every healthcare transaction, or in most healthcare transactions in the United States, there's really three parties involved. There's the patient, there's the provider, the doctor or the hospital, and then there's the payer, and that's the insurance company. The largest insurance company in the United States is the federal government through several different programs they have to insure certain segments of the population, including the elderly, the poor, military, etc. Historically, payers were the ones that were financially responsible for any poor care or exacerbated care or any care that led to more costly treatments. Ultimately, the provider was incentivized to provide more things because they got paid on a fee-for-service basis. The patient who had insurance was shielded from any of the financial decisions, and so when given a choice, they would always opt to have more because they were pretty much not responsible for the vast majority of the cost. And the payers were ultimately the ones who are at financial risk for any of the decisions being made. I think this new system is moving us towards having providers be at financial risk. And this represents a major shift in sort of who is ultimately responsible financially. By paying providers, for example, per patient per month that selects to come to them, the focus is now on keeping those patients healthy, because if they all get sick at the same time and rush down to the hospital is not generating more revenue to deal with them. And so the implicit and explicit incentive structure is to figure out how to keep those patients from needing more expensive services.
Will the new system be cheaper and more efficient? What's your expectation?
Healthcare dollars have been inflated at a higher rate than the rest of the economy. And as a result, over the last few decades of really runaway growth on healthcare spending, we have gotten to the point where not only is the United States the most expensive healthcare system per capita in the world, but it doesn't achieve the same outcomes that most of the developed world is experiencing as a result of their healthcare system. When you consider things like life expectancy or infant mortality or even the quality of primary care, the United States typically is average to below average when compared to the world, despite the fact that we spend 2.5 times more per person on healthcare services than the developed world. So we were really at a crisis mode of costs going up, care getting worse, outcomes getting worse. This is one of the solutions to try to control those costs at the system level. So I like the adage of an ounce of prevention is worth a pound of cure. And I think that's really the underlying principle of population health management. If we can figure out how to spend a little bit on things that will prevent us having to spend a lot of bit later on, both the payers, the providers, and the patients could win.
Changing from curing sick people to preventing illness means to take also social and environmental determinants into account. Does this lead to new data needs?
The more data a provider has about all aspects of a patient's life, the better they are able to deal and address the needs that that patient might have in their life that might exacerbate their health or exacerbate their disease. The more data, the better, including things like how well I exercise or what the quality of my nutrition is. These things used to be only intangibly of interest to providers. These were not things that really was the main focus of the doctor's visit. They might tell me, yes, you need to eat better or you need to exercise more, but it really was almost in passing. Now, these are the things that might get more focus and getting better information about those things.
What kind of additional data coming from smart health devices and smart watches and wearables could be used in population health management?
Yeah, so smart watches, step counters, all the different things that are tracking us are really allowing people for the first time to almost quantify some of their own health behaviors for use by themselves and perhaps by others, including their doctors and other medical providers. I think these kinds of data are very exciting because they could be integrated with clinical data to get a better picture of what's working and what's not. I always wonder how often people tell doctors who say, oh, have you been exercising more? And of course the answer is yes. I'm not going to let down my doctor by telling them, no, I'm not exercising, I'm exercising less. And so having some additional information that the doctor and the patient can talk about together, look at objective information, I think it could help the relationship between physicians and patients. Whereas previously the doctor would have said, well, okay, if you tried exercising and it didn't work, even though maybe I didn't, now he'll give me a more expensive drug, or he'll start thinking about more invasive sort of ways to manage my disease. But if he got a report that said, actually, for the last 3 months, I've been exercising less than previously, maybe the focus of the conversation could be re-educating me on the benefits of engaging in more physical activity, or engaging me with different ways to get around not having the opportunity to exercise.
You're a co-founder of a startup called oopshealth that provides data for population health management and also makes use of artificial intelligence. What kind of services does this company provide and to whom?
So yes, I am one of 5 individuals led by one of my colleagues that has sort of developed some technology that we think could be very useful in this population health management space in the United States. Our innovation is basically combining clinical data from a patient's medical record with additional clinical data available from medical records of that patient in other clinics or other locations. And we take that information and connect it with hundreds of variables from the patient's zip code that describe pretty much the social circumstances and all the different social determinants of health that that patient might experience as a result of where they live. So some of these neighborhood level data include things about what the smoking rate is in that community, what the unemployment rate is, what the crime rate is, how far it is to get to the closest grocery store that might have fresh fruits and vegetables. And we take all of this information and we tried to predict who might benefit from the use of a social service provider, such as a social worker or a nutritionist or a mental health counselor, for example. And we take that information and we try to provide it in real time to the doctor or the nurse treating that patient and recommend that this person be referred to a social service provider that they need, given everything that we know about them. This is exciting in part because the system has historically only used a social worker or a mental health provider after a problem has occurred. I think what we're trying to show is that if you identify the need ahead of time and address it before the patient has a complication or their disease or is exacerbated or their health is diminished, you could potentially save unnecessary utilization downstream. And so oopshealth is the Swedish word for upstream, in part because we believe we're trying to intervene with upstream issues that might affect the patient.
Do the patients know that the provider uses this system and that they as an individual are traced?
They are not traced. I think the patients know that the information that they give their providers is used to improve their care, but all of the information that anyone other than the medical doctor and nurse who are sitting there in front of the patient have is completely de-identified. And so the algorithms run without the ability for researchers or anyone else to know who is the individual. And so from a privacy perspective, there's no violations.
To what extent does oopshealth make use of artificial intelligence technology?
So our prediction algorithms use machine learning approaches. And so the information that we feed the system keeps getting better and better when we provide feedback back to the system from the social work and or from the physician and nurses on who was truly predicted to be someone at risk and was done so correctly. And so we are using these algorithms. They improve over time. And we've also shown in some of our published work that both the usefulness of our predictions have exceeded sort of some of the thresholds for being useful in clinical settings. And we've also shown that people who are referred to these social service providers ultimately reduce the number of emergency visits that they have in the next year, and they reduce the number of hospitalizations that they have in the next year. And emergency visits and hospitalizations are particularly important because not only are they very disruptive to patients' lives, but they're also very costly. And if you can prevent them with relatively simple and cost-effective interventions, everybody wins.
Is this just a concept or already implemented?
It has been live for over a year, probably a year and a half at this point, in 9 different clinics, all part of one large healthcare system in Indiana. And in fact, we won a couple of awards, including the Best New Disruptive Technology in Healthcare in Indiana, and we won a national award from the American Medical Informatics Association for one of the most exciting new healthcare technologies in that space. And part of the reason they were excited, and I think we've been winning these awards based on feedback from the judges, is that this is not a concept. This is not on the drawing board. It is in the clinics, it is running, it has been in use for more than a year, and we have several scientific analyses published on the impact and sort of the predictive properties of the algorithms that we've developed. And so this is very much in practice, and we're now thinking about identifying ways to move this algorithm into the emergency department. It's currently in primary care clinics or general practice clinics. We're going to be adapting it for use in the emergency department, and also identifying new things that we can predict by leveraging all the types of data that I described we have access to before.
Well, at the moment, this means that a doctor or a nurse who works in a hospital that implements your system has a kind of indication when he talks to the patient that there's a kind of pop-up window saying you should involve a social worker in this case, right? So this is a kind of additional idea of what the doctor or the nurse could do.
So that is not exactly correct.
Okay.
About 80% of the patients that are going to be seen at the clinic are known very first thing in the morning. So our algorithms run before the clinic even opens. And so we predict of the people that are showing up today, who is the neediest for these services. And so a nurse or a clinician makes a decision in the morning to co-schedule whichever social service provider our algorithm has identified that patient needs at the same time of the medical visit. And of course, the patient has said, hey, we believe you might benefit from also speaking to this nutritionist. Are you okay with this person being part of the visit today? And so this is much more proactive than a pop-up in the middle of the encounter that has already begun, and it might be too late. We have found that when you tell the doctor or the nurse that this person might need a social worker, they might refer them, but that patient may not find it easy to come back at a later date. And so we try to get, again, ahead of the situation by co-scheduling that individual. So the nurse and the hospital system is able to make better human resource decisions on how to deploy their providers in a way that addresses the people who need them most on any given day. Patients sometimes do not provide information that they view as stigmatizing to their doctor or nurse, in part because they view it as unrelated to why they're there today. And so I think in many ways we've overcome that by leveraging some of these data sources that are available.
And do patients like it?
The clinics that are using this technology are also using additional interventions to engage patients. They've recently implemented something called case conferences. And basically when there is a patient that the team is not successful in helping to address the needs of, the entire team, the doctors, the nurses, the social worker, the dietitian, the respiratory therapist, whomever is involved in that patient's sort of care, along with the patients, get together in a conference room to discuss what are the additional unmet challenges that the team can brainstorm on how to deal with. And patients really enjoy the ability to have these discussions. Sometimes it's, I just can't get to the pharmacy to refill my prescription. I find it difficult to, take off from work to be able to go to the other doctor that I need to go to. And so the team figures out what can be done about that to address whatever it is that's the barrier in that patient's life.
Did you involve doctors or nurses into your innovation team?
Absolutely. So our, the five of us, led by one of my colleagues that founded this company, are made up of doctors and public health professionals and machine learning experts and health administration folks. And we have worked very closely with one of the local health systems where this is being deployed in 9 of their clinics. And we have regular meetings with their doctors and their nurses and their administrators to make sure that this is working exactly the way it needs to. And in fact, lots of the feedback we've gotten on things as simple as, we don't want a score that tells us the risk prediction. We want it as a color, or we want it as a green, yellow or red. And how we've even over time improved the presentation of the results to meet their needs is really a testament to how closely we've worked with our partners.
What inspired you for this innovation?
So in the public health field where I have been trained and where I work, it has always been well known that the social determinants of health easily make up the majority of the drivers of both disease and healthcare service utilization. And in the United States, we have historically spent 90 cents of every dollar on medical care, despite the fact that medical care probably only accounts for about 10% of the variability in life expectancy and ultimately disease outcomes. And so the vast majority of the action is on behaviors that the patients engage in, whether they're eating nutritiously, whether or not they're educated, whether or not they exercise, whether or not they engage in certain behaviors. Another 20% is the environment that they're living in. That includes the quality of the air, the quality of the water, the quality of the food, and the quality of the shelter that they're exposed to day in and day out. It's not hard to imagine how degradations to the quality of air could very quickly result in health impacts on people. Same thing with water, food, and certainly shelter. And so between behaviors and the environment, 70, maybe more percent of the variability and health outcomes reside. And yet in the United States, we've spent little effort and certainly little money to address those issues. And every time the population gets sicker and worse off, we pump more money into the medical care field. And so to us, this has been very clear for a long period of time. It's now exciting that the financial system has changed on how doctors and hospitals are being paid. I think previously, if we tried to deploy this idea under a fee-for-service model, it would have been rejected, in part because it would have reduced volume and as a result negatively impacted the financial health of the hospital. When the hospitals and the providers are at risk, they're at risk for the patient's outcomes and the patient's health financially, they're much more incentivized to utilize tools that indeed potentially reduce the number of patients that they will have, but that's probably a good thing.
For many years you've been working in science, you're a professor of healthcare management, and now you're founder of a company. How did this change your life, and what did you experience about these different situations, being a researcher and being an innovator?
So the team, and all of us are academics, frequently jokes that as excited as we are about the potential to have an impact on people and people's health as a result of some of this work, we joke none of us wants to leave our day job. in part because it's an overwhelming new space that we're just not fully aware of all the pitfalls and all the opportunities and how to avoid the pitfalls and take advantage of the opportunities. And so one of the things we are considering, which we think is in the best interest of everyone, is to hire a full-time CEO and get this, professionally managed with someone who has experience in navigating the venture world, the electronic health record world, the business world, with the skill sets that we just admit we don't possess. We'd much rather continue to innovate and maybe invent new things, maybe apply this to new opportunities, and more importantly, scientifically evaluate the impact of these things. I think what brought each of us to academia continues to want to keep us in academia. And so the worlds couldn't be more different.
Thank you very much.
Great.